She lives in Idaho in a lot of sun, and she's out a lot. So I'm going to put that down to not anything I can change. She doesn't have scarring. She doesn't have pain from that. There's no sequelae. Costochondritis, inflammation of the cartilage in the rib cage. That is not a current problem. So we kind of ignored that, blew past that. Huge nervous system reaction to Imitrex in January of 2005. I want you to put a pin in that because she has a set of symptoms, tightness in the throat, that she insists is from this Imitrex reaction. I suspect that the Imitrex reaction just scared the hell out of her. She used Imitrex a lot for migraines, and it was just an awful reaction. That was January of 2005. However, look at what else happened in 2005 that does happen in the neck. Parathyroid hormone was elevated in 2005. So her serum calcium was wonky, I think is the technical medical term, February of 2005. So the inflammation in the parathyroid from an autoimmune reaction probably started back in January. Yeah, if you have questions, type them to Kevin. And is that by email? Do you want them?
No, they'll just
in the
chat feature.
In the chat feature of the app. Parathyroid is elevated. Abnormal parathyroid gland. Nuclear scan, one of them is hot. They took that out. They had parathyroid surgery. Normal was 30 grams. Hers was 300 grams. So she had one of the parathyroid glands was removed, and it was about 10 times normal. Now, she's had right arm and hand pain, maybe related to her neck since September. So for 10 years, she's had arm and hand pain on the right. Candida, saw, I think that's a chiropractor or naturopath, fatigue and sleeplessness, disc bulges. So somebody told her that they repaired her disc bulges. Sinus infections from 2014 on. Ice pick headaches started 2015. Put a pin in those two because we're going to talk about those in a bit. She had a facelift, neck, and eyelid lift surgery in January of this year. Why somebody with her health history would do that, I don't know. But as a friend of mine suggested, it's like she just wanted to feel better about herself. And she's 68, and her husband had already had a facelift, and he's 71. And so it's like, well, why not? Well, then she had a bunch of symptoms that were secondary to that. The super dry eyes began after the eyelid lift in January of 2017. So that's got to be one of the scariest, most obnoxious histories I've ever seen. And there it is. When you put it into groups, it's not all that awful, right? Okay. So this is my pain diagram for the clinic, and there's a front, the side, and the back view. And she's got all these things circled. So her husband's an engineer, so the next thing they did was break them down into 17 different pictures. So the first grouping, and I got 17 pages, and I had to put them sort of into groups that went together. So these were all different in her head. Left shoulder, the right side of her neck, those were different. Right arm, right side of her neck, left shoulder, right thumb, all different, right? Then she had knee pain when riding horseback. No known trauma. No, what's the matter?
Just real quick here. Sure. We've got some people saying that they can't hear you very well, so
you have to bring it up.
I was going to try and move that microphone level up a little bit more, see if that helps you.
Is that better? Can you all hear me? Trouble hearing me? Okay. This means you're also probably going to hear the dog barking in the background. So there you go. All right. So she had knee pain when riding horseback. She had to actually stop riding horseback, but no knee trauma, no known cause, just this random unexplained knee pain. Well, when I did, the cervical exam was fairly obvious, range of motion, sensory exam, she was incredibly hyperesthetic at C. 6, 7, 8, C2 was wicked hyper-aesthetic, and L5, which was interesting, but not L3. L3 was not that bad. But her adductors and quads were incredibly tight. Actually, L3 was hyper, now that I think about it. Adductors and quads were incredibly tight, and those of you that know about treating loss of descending inhibition, this is characteristic of spasticity or loss of descending inhibition secondary to spinal cord inflammation. So when the spinal cord gets inflamed enough, it doesn't just create pain, it creates, if the disc is in the correct place, it'll create loss of descending inhibition. And tightness is it's an odd kind of feel. It's just the increase in tone or spasticity in the lower extremities is really characteristic. Once you find it, once you fix it, you kind of never forget what it feels like, and it's just tight. No other way to put it. So, Lou, great, terrific. Hello. I can't get it to switch. There we go. Here. Okay. So, migraines. She has all these headaches. So when I say all different and all the same, she didn't put the arm pain, the knee pain, right arm pain, right thumb pain, left shoulder pain, both knees, and then her left heel. She had, it just hurt when she lifted her heel. It didn't hurt when she stood on it. It hurt when she lifted it, when she walked. Makes it better when she sits. Makes it worse when she moves, stands, or lifts her foot. That says it's her Achilles. So put a pin in that. And I think what's causing this Achilles is the loss of the descending inhibition, again, doesn't just increase tightness in the hamstrings and the quads. It causes tightness in the gastroc, which can lead to an Achilles tendinopathy, right? All different, all the same. These were all listed as different problems. So this is what, 8 or 9 of the 17 migraines? Well, they were not associated with anything she ate. They did not have an aura. She never got the visual disturbance that you find with classic migraine. They were not associated with her menstrual cycle. They started when she was young, but before her menses. So you could think maybe it was related to gluten sensitivity. But she, again, had headaches, not just migraines, every day. So they're intermittent, but daily. So she wakes up with a headache, or she gets what she would describe as a stabbing posterior migraine. Look at where it is. You see that? See the arrow? See the pain diagram? This is why they fill out a pain diagram. That migraines don't happen in the back of your head. You've seen patients with migraines. They describe the front, right? Or the whole head. They're throbbing. It's inside the head. Nobody describes the distribution of the occipital nerve or the C2 nerve root as migraine. She didn't know what else to call it, and her doctors called it migraines. She had general headaches, tension headaches, daily. Then occasionally the tension headaches got really, really, really bad, and she described those as migraines. So these, I think, are roughly the same thing, because look at the pain distribution. That's the C2 nerve root. So that's where I'm going, looking at this. Then I asked her, now, her history didn't include any sort of history of trauma, except you always ask about that, right? So I said, do you have any history of trauma? She didn't put this in her history. She rode horses as a child, starting when she was 6 or 7, and she fell off a lot. She apparently had a fairly cranky quarter horse. who dumped her as a routine thing. She had a bunch of auto accidents as a teenager, maybe 3. She was lifting boxes, and she does painting around the time that the arm pain started, and she described herself as falling off of horses dozens or hundreds of times. So the history had gone on at that point for about 2 hours, and I just needed to get to treating her. So what was bothering her the most was just the arm and neck pain. It's like, look, I'm going to worry about the rest of this later. So we're going to treat the worst first. The thing you care about the most is the headache and the neck and arm pain, right? Yes, please get rid of that. So I did a physical exam. Range of motion was rather limited, especially in extension and actually somewhat extent in flexion. Her reflexes were interesting. Her patellar reflexes were not, yeah, they were brisk. They were like a +3 with a little bit of crossing, not as much as I would have thought, but the most abnormal one was her Achilles. She had a brisk +2, really vigorous Achilles reflex. Well, the problem is that the Achilles reflex in a 68-year-old should be gone. There shouldn't be an Achilles reflex. There should be a +1 reinforced in a 68-year-old female. There shouldn't be an Achilles reflex. So in my mind, a +2 vigorous Achilles in a 68-year-old female is abnormal. So I put a pin in that, and that says something's messed up with the neck. And then I palpated her legs on my way up, and she's laying supine. And it's like her leg tightness was really, really distinctive. So later down, I had one machine, neck to feet, running 81 and 10. I think that was my blue box. Neck to arms was an auto care, just running 40 and 396. So I went to the nerve pain protocol and just did 40 and 396 and sort of fast forwarded till I got to 40 and 396 and then pushed the hold button. And that's how I ran 40 and 396 for the whole time because her arm pain was the most obnoxious. Neck, and there was a second. So this one was tower on the neck. So machine number 2 was neck to arms. Machine number 1 was neck to feet. And these were both, the red leads, positive leads were in the wrap around the neck, down to the hands, 40 and 396. And then neck to chest was my precision care. And that was basically the supine cervical practicum, 40 and 94 to quiet tender trap in our SCM, torn and broken in the ligaments, 40 and 10 to just quiet down the cervical paraspinals, 40 and 710 to quiet down the disc, scarring in the dura, 13 and 443. And then that right-sided neck pain, remember that? The neck pain that she complained of, that was facets. Part of it was disc, but part of it was facet. So I did inflammation in the cartilage, inflammation in the periosteum, inflammation in the disc, in the joint capsule. That didn't do much. Hardening in the joint capsule, that's always a nice one. And then scarring in the nerve, scarring in the joint capsule where the facet joint is innervated, where that medial branch goes across the facet joint. So scarring in the, and then I went back to scarring in the dura and scarring in the nerve and turned her head and mobilized her neck a bit to loosen things up. And legs relaxed, everything got smushy. At the end of it, she was pretty stoned, and her arm and neck pain and shoulder pain were completely gone. When she sat up, her left shoulder was still sore when she moved it. So I think I got my fingers in her armpits and ran 13 and 396. In her axilla, that sort of freed up the shoulder but didn't fix the left one. So she's got a partial thickness tear in the left rotator cuff. I think the tear is the name for spinatus probably. But she was okay with that because I told her we could treat that later on and she could treat it at home. But basically she was pain-free at the end of 90 minutes. They saw me 4 hours, I think, at the first session. And this is a luxury, right? It's like I've got a crazy practice where I'm just not that busy. So I could have them be, I'd already had 1 or 2 patients before them. They were my last patients for the day, and I was with them for 4 hours. The first 2 hours were history, and that might have been 120 minutes. Second 2 hours were treatment. But she left pain-free at the end of it, so she was happy. That was encouraging for somebody that's been in pain for this long, and for whom the pain is not a mystery. So there are 2 gifts here. One is for pain to zero, but the other is all of this is coming from your neck, and your leg tightness is coming from your neck. Ah, that was news. So the second day, we got down to the left heel. That was a puzzle, right? No trauma, sensory exam, S1's normal, straight leg raises normal. This is not sciatica. This is not S1 nerve root, right? However, and the pain is worse. It's like a ball. This pain is worse in her heels when she lifts her heel than when she moves or when she stands. Anytime she's standing or contracting the muscles in the back of her leg. Loss of descending inhibition, same problem is causing the knee pain, right? So the nerve tightness and muscle tightness in the legs had come back a bit. So we ran 1 machine neck to feet on 81 and 10, knee to left foot. She had Achilles tendinopathy. So torn and broken in the tendon and the connective tissue, and then scarring in the nerve. So we had those 2 machines running that. And then our goal for that second day was to treat facelift pain and the nerve injuries. So how do you do that? Okay, so facelifts. Here's the thing. The guy did a great job. This was a facelift that looked completely natural, wasn't too tight. They make an incision behind the ears. They loosen the skin with blunt dissection, and they move it up. Her no ridging of scar tissue. He took away just the right amount of tissue. It's a beautiful job. However, she had burning pain on the jaw, the face, the back of the head, behind her ears, and her ears burned and tingled, and then up the back of her head. Well, the thing with facelift is when you peel that skin off the nerves, they're like little teeny spider webs. You've had anatomy, so you know what that's like. So, pulls the skin and causes traction injuries in the nerve, and then the bleeding causes scarring. So we had the 1 machine, neck to feet, and I put a second machine in the towel around her neck and put a washcloth on the black and yellow leads from the, or the black leads from the blue box, or black and yellow leads from the precision care, and put a washcloth over her face and the back of her head. She had, we parted her hair and treated the C2 nerve root up the back of her head for 40 and 396, and just treated the nerve traction injuries with it was simple, 40 and 396, all polarized positive, treated C2 first from the neck up to the top of the head, and that took care of that. Then treated the nerves for scarring, and actually neck to face and neck to the top of the head, so C2 and the cutaneous nerves in the face. Then what gets scarred when you go around healing up the skin and the fascia? Well, scarring in the nerve, yeah. Scarring in the skin, 355, 142, the fascia, the blood supply, and the connective tissue. And we just treated that for scarring. And then the sides of her head and the back of her head were, there was no give. You know, if you put your hand on the back of your head and you press down on your scalp and you go wiggle it, it wiggles. There's about half an inch, centimeter and a half of play in moving the scalp. Well, her scalp didn't move at all. So it was scarred down. And if you remember that diagram from the advance, there's the scalp, there's blood supply, and there's connective tissue, blood vessels, and nerves. So I did scarring in the nerves, scarring in the blood supply, scarring in the periosteum, and scarring in the connective tissue, and then scarring in the scalp. Well, at the end of it, her scalp was nice and smushy and mobile, moved around fairly nicely. So that worked. So this is always a tentative discussion tentative diagnosis. It's like, I think this is what it is. So you create a hypothesis. I think it's going to be inflammation and scarring in the nerves and all the rest of the stuff that goes with that. And then when it works, it's like, okay, you were right. Sciatica, or not sciatica, see this little dot, this little circle, right? Is it the SI joint? All those falls off the horses? Is it the L4-5 facet? Coughing and sneezing make it worse. Movement makes it worse. Spreads from her SI joint down her legs, so it could be sciatica. It could be a disc, could be the L5-S1 facet, could be an SI joint. As it turned out, I didn't end up having to do a whole lot with this because it just stopped being a problem when everything else went away. Upset tummy usually occasionally happens from food and meds. Last week, October 17, intermittent, sharp, achy, numb, sharp, achy, stabbing. Pepto-Bismol or vinegar water seem to help. Ice seems to help. Look at where it is. It's kind of low, right? It's not up here. It's not in the epigastric area. It's a little bit low. So this episode, this was October 17, they were supposed to have come maybe a week or two earlier, and they had to reschedule to last week because she ended up at her age with appendicitis. And she got the appendicitis, she got to the hospital, and it turns out she was in atrial fibrillation, probably secondary to the inflammation created by the appendicitis. So they put her on antibiotics. They couldn't do surgery for the appendix because of the atrial fib. So they just put her on antibiotics for the appendicitis, and it makes you wonder why everybody with appendicitis isn't put on antibiotics instead of surgery, but that's another conversation. And atrial fib. So her heart rate was still a little bit funky. She was a bit tentative. They converted her a couple of times, and it finally stuck. So that was behaving itself, but she wanted me to treat her. So I did 81 and 109, increasing secretions in the vagus from wrapped around her neck down to her abdomen. Did 81 and 109, increasing secretions in the vagus nerve with the pulse oximeter on her finger. And then quieted the sympathetics, 40 and 562, and then inflammation in the heart. Now, she was on antibiotics for the appendix, so I didn't have to worry about reducing inflammation. So her heart rate went down, where it belonged, 67, 62 in there someplace. So that was her normal heart rate, so she was happy with that. Then the abdominal pain, if you look at scarring in the connective tissues, scarring in the vagus, the small bowel, the appendix, and the cecum and the ascending colon, treated those for adhesions while I was down there. And that put a pin in it. That is kind of takes us back to that first page where we're checking for gluten sensitivity with the genetic testing from enterolab.com and ordering the HLA-DQB1 test. So that's how you sort that one. This is day 2. Now, if she was local, if I had the option of seeing her 3 times a week, I'd treat her for 30 to 60 minutes at a time and treat her 3 days a week for about 4 weeks and get this all done. Instead, they got, 12 to 16 hours of treatment in 3 days. 3, 6, 6, and 4 times 10 hours is what she had in 3 days. So this was interesting. Remember the sinus infections? She started getting sinus infections 1990, but I think they started being a real problem in, 2000? Somebody remember from the history. I'm going to flip back through this. Don't get dizzy, okay? Come on. Oops, going the wrong direction. Thanks. Come on. Come on, come on, come on, come on, come on. History, right? Sinus headaches. Sinus infections, 2014 on. And then the ice pick headaches started in 15. So keep those two together, okay? The computer has a little bit of an objection to all the pictures on these slides. All right, we're back to, sinus infections and ice pick headaches. Sinus infections started in 14, but you notice that in her history, she said they started in 14. When did she notice then the first? She said 1990. So there's 14 years worth of history there that kind of doesn't match her original history. Sinus headaches, consistent every winter, same every winter. She always gets a sinus infection, consistent during the winter. Every winter she has a sinus infection. Every winter she's on antibiotics, okay? Doesn't cause any pain, it's just annoying. That's what helps is antibiotics for the sinus headaches, sinus infections. Then she had ice pick headaches on the right side of her head starting in January 15, and they continue up to today. Ice pick headaches on the right side of her head, and she pointed to the temporalis muscle. So put a pin in that. And I don't have a diagram. That's one of the pages of pain diagram I'm missing. Ice pick headaches on the right side of her head, and she's pointing to her temple and the temporalis muscle. And then this was odd when she was describing her right shoulder pain. Now, C5 nerve pain is up at the deltoid, and they tend to put their hand around the deltoid and then go down. She described her right shoulder pain by tracing her hand across her chest, just above and below the clavicle, into that space right over the coracoid, and then up the side of her neck. It's like, that seemed odd. And so she went from the ice pick headaches on the right, and then down this right shoulder, like somehow her hand thought they were connected. She didn't think they were connected in her head. The shoulder went with the neck as far as she was concerned. But you don't get shoulder pain above and below your clavicle from your neck, right? Not unless it's T1 and T2, and sensation in T1 and T2 are normal. So put a pin in that, okay? So then comes the questions. When you see somebody with sinus infections and with a history of appendicitis at the age of 68, something had to feed the infection in her appendix. She has no foreign travel. It's not going to be a parasite. How did she get acute appendicitis at 68? And why does her sinuses get infected all the time? And why does she have a headache on the right side of her head in particular and the right shoulder? Obvious question for me, given especially my patient population and my own personal history. Have you ever had any root canals? Yes. When? 2013, I had a really deep filling with a crown. 2015, I had a root canal. Where? On the upper right side. And I think she thinks she has a crown on the left as well. So that got me on to the root canal story. Palpation of the lymph nodes on the right side of her neck, up under her ear, up under the jaw, and the upper chest. They were tender and congested. When you tap on the sinuses and you and I had her put her finger in her mouth and palpate the right upper gum, it's very, very tender, very tender. So as far as I'm concerned, she has an infected root canal and a tooth. She said, yeah, the crown on this tooth is loose and it's sore. They need to glue it back down. It's like, no, they need to take the tooth out. So she's going to go back, see if she can find an ICAT, get a 3D cone beam, find a dentist that'll have the tooth removed and treat the jaw infection. So as far as I'm concerned, the headaches, the right anterior shoulder pain, and the sinus infections and the appendicitis are probably all seeded from this bad root canal, 2 root canals, a root canal and an infected tooth in her jaw. So you have to ask, put the pieces together, collect all the pins that are in various places, and make that get you to ask questions. This,
It's not TMJ.
it's not TMJ, no. No, it's TMJ does not cause swollen lymph nodes and does not cause sinus infections, and it does not cause appendicitis. Her jaw didn't click. I mean, it's not a bad question, but it could have been with all the falls off of horses, but TMJ doesn't cause lymph nodes and fatigue and tightness, inflamed and congested lymph nodes in the neck and upper chest. So my money is on root canals and a jaw infection. TMJ is not going to kill her. Root canals and a jaw infection will. That will cause heart disease. So, and a 68-year-old, it's a lot more important to assess the root canals and the jaw infection and get that taken care of. TMJ never killed anybody, and she doesn't have a lot of pain in her jaw. She has sinus infections. Pain in her face was from the facelift and the nerve irritation. It's not an unreasonable question, actually. Okay, throat tightness. She absolutely swore that this Imitrex reaction in 2005, it was in February of 2005, as I recall from the history. It's February of 2005. She kind of, you look down on the history, the Imitrex reaction was in January. Parathyroid, elevated parathyroid hormone was February of 2005. The scan was hot in May or June of 2005, and the surgery was in 2005. She was convinced that this tightness in her throat was somehow connected to the Imitrex reaction. And it was actually fairly difficult to get her off of that. It's like, wait. You had surgery on your throat in 2005. Imitrex, your reaction to Imitrex does not cause scar tissue in the throat. The parathyroid autoimmune reaction causes inflammation, and that'll cause fibrosis. And the tightness and the discomfort in your throat, can't tip her head down, can't swallow comfortably. We treated that with scarring in the connective tissue, scarring in the fascia, scarring in the parathyroid and the trachea, and then the pharynx and the larynx. And this whole thing just turned to butter in something under 5-10 minutes. It was nuts. I think I treated it the first day. So that was pretty amazing. That was just like, that was really fun. And she finally got over the fact that it got used to the idea that it was not an Imitrex reaction that caused the throat thing. And she didn't care as long as we got rid of it. She didn't care. So then on day 3, what we had left was the anal or rectal pain. I was kind of leaving that till the end, so to speak. But for when you've got a more developed relationship with the patient, and so what's going to cause it? Well, she's had colonoscopy. We know it's not colon cancer, so I'm not looking at a big tumor back there. It's not constant. It comes and goes. Bowel movements, don't make it worse, don't make it better. They're uncomfortable, but it's not horrible. Comes and goes. It's not related to her back pain, not related to bowel movements, but there is a feeling of pressure and fullness in the whole pelvic floor when this pain is present. So my working diagnosis was that it's a hemorrhoid. It's an internal hemorrhoid that gets congested on and off at various times. And so I had her lay on her right side because her left shoulder was the one that was sore. Had her gowned, had her underwear off, put a drape over her, so she had a fuzzy blanket on her to cover her. Once a patient's covered, you can do just about anything. So I put just the blue box because the buttons are easier to push. Red leads around her in a towel around her waist. Black leads in a washcloth that I put basically in between her butt cheeks, and you could feel the scar tissue from this old hemorrhoid. She had an external hemorrhoid or 2 that were dried up. It was just fibrosed and scarred. And when you palpated the anus, the give that should be there was not there. There was stiff and it was tight. So I did scarring. What's a hemorrhoid? Well, it's a vein. All right, so scarring in the vein, 79. Hemorrhoidal tissue is also described as 65, which is also the descending colon. 88, which is the rectum. 72 and 74, which are the anus. And then in the advanced, hemorrhoid is 65 on 88. Don't entirely understand that. Did 40 and 284 in the vein, the rectum, and the anus. And then went back and treated scarring. I think I might have done scarring in the artery as well, but scarring in the connective tissue I don't have there. Put 77 in there because it was connective tissue here that was a big thing. And then when it flares up, pay attention to the diet and liver congestion. So we'll have her treat liver, what's my battery? What is my battery?
Is your battery 22?
I don't know. Yeah, I've got 23%. We'll make it. And treat the liver when it flares up. My power cord's upstairs. So they went home with the custom care Friday afternoon. So the only thing I treated on Friday was the anal and rectal pain. Everything else did good. Her legs were still loose. Her knees were fine. Her heel was fine. Her neck and arms were fine. Her face was fine. She had no resting pain. Her ears still tingled when she touched her ears, but the face pain and the head pain, no headache for 2 days. It was like all gone. So she was a happy camper. So Friday, I just treated the anus, and I think I treated her husband's knee while I was across the hall programming custom care, concussion, nerve pain, neck pain, low back pain, neck and shoulder. So the nerve pain was for her arms, neck and shoulder was for that left shoulder. It's a combination of the disc and then torn and broken in the connective tissue and the tendon. So that's a mechanical problem, plus inflammation in the bursa and the periosteum. Tight legs was 81 and 10. So her custom care says tight legs, but it's 81 and 10 that runs for 60 minutes. Protocol for hemorrhoids, protocol for liver support, and then the usual things that you'd send home with anybody: cold sinus, cold throat, sleep, emotional relax and balance, shingles. Everybody goes home with fracture. Everybody goes home with strain. Everybody goes home with delayed onset muscle soreness. Everybody goes home with. She went home with AFib on hers, actually. Okay. So that was a very happy ending. She was a very complicated patient that ended up being really, I wouldn't say exactly simple, but it was a good problem-solving session because you had to group things together and look at what caused what. Because with her feeling about it was all thrown up against the wall like confetti. There was no order to it. And when you have the ability to treat one thing at a time or two things at a time or four things at a time, you can group them and get rid of a bunch of them together. So that was really fun. They were just delightful people, I thought, based on that history. Now, her husband's an engineer, which is why her history was organized the way it was. And so I thought she was going to be kind of high maintenance, and she wasn't. She was just adorable. She was just in pain. She was very stoic. Oh, that was the other thing I ran at the very end on that last day. That's what I forgot. The very end of the last day, I had said to her, "You're just super sensitive." And because of the early childhood trauma, not emotional or physical abuse, but just falling off horses and getting hurt a lot, I ran 40 and 89. I just had her hold the gloves in her hands, ran 40 and 89 and 40 and 92, and just quieted down her hypersensitive sensory system, okay? All right, so that's that case. This one I've been meaning to tell you about because it's a protocol I created in my custom care mode bank, my very own. So on the custom care, we have a small intestine protocol. That's sort of standard, right? It's in the GI section, small intestine, and inflammation and chronic inflammation come way up towards the front, right, in that protocol, and 64 and 42, 64 and 63, 97, 40, 98, 20. Can you bring the dog in? Can you bring him in? It's driving the neighbors crazy. 64 and 42, 97, 40, and 98, 20. And for SIBO, the problem is dysbiosis and infection, basically, in the small intestine, abnormal bacteria. So you can you clone the small intestine protocol and then change the sequence, move the items in sequence. So move 64 and 42, 64 and 63, 97, 40, 98, 20 up to the front of the sequence. And you might also add 44 E. coli, which belongs in the large bowel but not the small bowel. You can do 44 and the small intestine up to the front, increase the time that they run, and move 40 and 284 way to the end of the sequence. So now you have a protocol in your mode bank that you call SIBO, because that's kind of the new diagnosis, right? And that's how you do it. You don't have to write the whole thing. You just clone, go to that little icon in your custom care that says clone the mode, and copy it. Move these things up to the front, add 44 and 22, and increase the time that they run, because I think they run for 1 or 2 minutes. Run them for 4 minutes apiece, and then move 40 and 284 way to the end. This is not a one-visit fix. Obviously, it takes some doing with probiotics and dietary changes, but FSM makes it just not that hard. We've got about 10 minutes. I can't remember if I showed you Diana Cross's presentation on the Vegas. She is going to come to Las Vegas in 2019, and she gave this presentation at the Australian follow-up, or update, Australian update that she hosts every year in Sydney. And so this is her presentation on the Vegas. They are starting to use an experimental procedure that shows the connection between the nervous and immune system. This is Douglas Fox in the Nature News feature in May of 2017. Vagal nerve stimulators are being researched for their use in rheumatoid arthritis and inflammatory bowel disease like Crohn's and ulcerative colitis. Also in development for migraines, diabetes, obesity, and we already know they use it for depression. So it's an implanted vagal nerve stimulator. It is not without consequence or risk. Settings are in, I'm not sure if that's microamps or milliamps. The frequencies are 1 to 30 hertz, on, off, on, off. It's a pulsing sort of sensation. There are side effects to it. Here's the thing, I didn't know this, the left vagus carries parasympathetic fibers to the ventricles. The right vagus innervates the atria. So in atrial fib, you want to primarily focus on the right vagus by wrapping the right side of the neck and going down to the chest, and that's an atrial fib. In the left side, you're treating ventricular tachycardia, but you also want to think of treating the spleen on the left side because that's what affects the immune system, vagal nerve stimulator. So here is Diana's thought process for using the vagal nerve stimulators to treat inflammation. I've got to show you this picture. It's so cool. So there's the course of the vagus nerve, the pons, inferior and superior ganglia, the medulla, pons, medulla, the vagus. Look at this. Innervates the pharynx, right? And the larynx. So when Tom had a hoarse voice and a rapid pulse and digestive problems after his auto accident, we treated his vagus nerve for scarring while we increased the range of motion in his neck. And when he got up off the table, his voice was just fine. And that's because of this branch. Okay, carotid sinus, laryngeal branches, right? The lung, the heart, and there's the branches to the spleen, the liver, the gallbladder, the stomach, all the intestines. Okay? And there is an auricular branch to the ear, the thing that makes you cough when you are cleaning your ears is the auricular branch. So the reason they're studying obesity is the sense of taste, the feeling of hunger, and the feeling of gastric fullness are all related to vagal function. Abdominal pain and discomfort are mediated by the sensory functions of the vagus. Parasympathetic stimulation of the vagus nerve increases muscle tone, strength, and peristalsis of the intestines, thereby intensifying its motor actions. Swallowing, speech, gastrointestinal slows the pumping of the heart and constricts the bronchi. So these are all things you have to watch when you start messing with the secretions in the vagus. So you are not to treat the vagus unless you have a pulse oximeter on the patient. But here's this little auricular branch. It's a way that we have of being able to access the vagus directly, although the skin seems to be an adequate conductor. Left vagus, the ventricles, right vagus, the atria. Okay, inflammatory reflex. Here's the interesting part. So the vagus coordinates the nervous system, nociceptive reflexes in the lungs, neuromodulation of antibody reactions by way of acetylcholine, innervation or signaling to the macrophages and the T cells. Vagus innervates the adrenals, which stimulates dopamine, which regulates inflammation. So you have, it down-regulates inflammation for when you're in the fight or flight, right? Vasoactive intestinal peptide, interleukin-5, allergic lung inflammation, all of this is related upstream or downstream to the vagus, acetylcholine, norepinephrine, and neural reflex in cancer. That's another conversation. So infection or tissue injury, right? So when you get injured, things get activated. When you get an infection, they get activated. Activates the macrophages, increases cytokines. Cytokines go up, kill the bacteria, the injury gets repaired, you get healthy. If it doesn't get repaired, you get non-resolving inflammation and chronic immune system activation, which leads to rheumatoid arthritis, atherosclerosis, inflammatory bowel disease, multiple sclerosis, certain cancers. And when the cytokines become chronic, you have what they're calling sickness syndrome, swelling, loss of function, tissue injury, pain, anorexia, fatigue, shock, and fever. So the vagus and the nervous system, the sympathetic and parasympathetic nervous system, is intimately related to all of this. So periphery, the macrophages send signals report to the brain about PAMPs and DAMPs, so the infectious or inflammatory stimulators via the afferent vagus. Who knew, right? Okay, so the brain sends stimulus down the celiac ganglion via the efferent vagus to stimulate the spleen, to activate the immune system and activate the macrophage response. Cool, huh? From the celiac to the T cells in the spleen which in turn signal the macrophages to go get them, do their job. And the macrophages increase, TNF-alpha, interleukin-1, 18. Isn't this nifty? All right. So, if we can, okay, cytokine production goes up, and that attenuates, takes down the inflammation, right? Cytokines go up, that kills the bugs, and that quiets. So pathogens, ischemia, injury, cytokines. So there are times when that's good. Cytokines are required to cause tissue recovery, assuming they're balanced. If everything stays functional, it balances. If it gets unbalanced, you have tissue injury and chronic unresolving inflammation. And this is why Harry said that the medulla regulates immune system response. So we have two ways of approaching this whole conundrum, and that is by the concussion protocol and by treating the vagus nerve. We can do 40 to reduce inflammation peripherally, but what if we treated the vagus? Monitor with a pulse oximeter, left side of the neck, and the external auditory canal. Kind of stick a corner of the towel in the left ear and pick up the auricular branch of the vagus nerve. You do the other towel on the left side of the spleen specifically, or you can go to the abdomen of the feet. I just go for the spleen myself. Simulate 81 and 109 because the reflex is an inhibitory one. So you want to increase the activity of the vagus to get the vagus to inhibit the inflammation that's happening here. Get it to do its job, which is to turn all of this off. Okay? 81 and 109. So the studies suggest that it just takes brief but daily. So you could theoretically prescribe somebody custom care with not 60, because that'll be 60 minutes, but 1 minute. Do it daily, do it every day. Run the concussion protocol every day. Diana thinks maybe down to the leg of the soleus. I would tend to stop. Can you hear me?
I can.
Okay. I would tend to stop at the spleen. Yeah, that's as high as the volume gets, you guys. I can sit closer to the speaker.
No.
Okay. So there are more references, but I thought that was really important to know. So stay tuned. I'm going to do more about this at the advanced. Diana's going to come in 2019 and have this discussion with us over a 60 to 90 minute thing, probably at the symposium or maybe at the advanced. I love it when she comes and lectures. She always has such great ideas. So that takes us to the advanced of this year, February 27th and 28th. Mark your calendars. We have a new feature, which is the FSM Sports Seminar, 2 days with Kim Pittis. And she's going to be at our hotel at the Crown Plaza, San Marcos in Chandler, Arizona. Nice place to be in February, especially if you're, I don't know, any place north of Reno. And March 1st, Jay Shaw. I've got to send out a newsletter with information about Jay Shaw. But Jay Shaw is why we run 40 and 10. Jay Shaw is why we run 81 and 10. Jay Shaw is why we know anything that we know about central sensitization and spinal cord sensitization of pain. When you're treating a patient with abdominal pain and pelvic pain, you run 40 and 10 on one machine and you treat the abdomen with the other machine. Jay Shaw is the reason we do that. If his slides were the only reason you came, it would be worth it. I have him back. This is his second time for us because I love his slides. They're just amazing and they're so informative. And you have a tool. He can describe it. You can do it. And it's why he loves talking to our group, because everybody else, it's theoretical. For us, it's practical. How do we do this? When do we do this? Why do we do this? Who do we do it on? How long do we treat? It's magic. March 2nd and 3rd at the advanced, lots of new frequencies. I'm doing the workshop schedule now. That'll be out in a few weeks. Your favorite speakers are coming back. I can hardly wait. And then March 4th, Sunday, there's practicum instructor training. The practicum instructor training trains table-side assistants for the core seminar and also trains people so that they can do the practicum trainings for people that have taken the course by DVD. Don't forget the resonance effect. Yeah, don't forget the resonance effect. Spread the word about what you do, why you do it, and how well it works. The reviews have been great, so I feel confident recommending it to everybody. It's a page turner. Loan or sell the book to your patients. People tend to love the story. And build awareness about FSM and the frequency effect. That's why we're doing this. So here's what you do. Y'all are changing medicine one patient at a time, and you are changing lives one practitioner at a time. That's what you're doing to the world. And when you change just one patient's life, you change the world. Join us next. We're not going to do a webinar next month because I'm going to be gone all month. I'm going to London on November. Where am I leaving?
November something.
November 9th, I leave for London. I go from London to Frankfurt to lecture at the Time Waiver Conference on November 24th, 25th, 26th. There's an FSM core seminar in Nuremberg on December 1st, 2nd, 3rd, and 4th. It's a 4-day core. I speak in English. They translate it into German. If you want a trip to Germany, come on down. There's a great Christmas festival in Nuremberg that weekend. And then there's an advanced with just me and some practitioner case reports for 2 days the following weekend. So I will be home December 12th. My brain usually arrives around the 15th, so we might not do a webinar in December either. It just kind of depends. Have a great Thanksgiving, and thanks for joining us. Keep up the good work, and we'll see you next time.